Thank you, Brian. So we'll move from small renal tumors to locally advanced tumors. In this session, I'm going to give a brief introduction or a little overview with a case, and then we'll have two speakers, Dr. Blute from the Mayo Clinic and Dr. Jonesh from MD Anderson, who are going to address particular aspects of the management of locally advanced kidney cancer. So what is locally advanced kidney cancer? Traditionally, when we talk about locally advanced tumors, we're primarily talking about tumor stage. So if the last session was really addressing these T1 tumors, T1 and T2 are organ confined. As you get into T3 and T4, these are locally invasive beyond Gerota's fascia. And then even patients with minimally regional nodal disease would still be considered locally advanced. However, this is how the survival breaks down when you look at tumor stage alone. And we're talking about these T3 and T4 tumors, and you can see there's significant risk of death from kidney cancer progressing as you go to each additional stage of the TNM local stage. But there are other ways of looking at locally advanced, because really what we're talking about in locally advanced tumors are risk of having disease progression or disease recurrence, and there are other variables that can place somebody at high risk for recurrence of tumor. So there are other factors such as tumor grade, for example. And you can see as you progress on tumor grade, even within local tumors, or non-metastatic tumors, as grade increases, your risk of recurrence increases. And if you have a grade 4 tumor, your median survival is only 11 months. So these patients are also at high risk for disease progression. ECOG performance status is another factor that we've looked at. And once again, as you have increasing impairment of your performance status, you have increased risk of death from kidney cancer. And what we've done at UCLA is combine those three factors into a risk stratification. So when we're talking about locally advanced, we can also think of it in terms of high risk for local recurrence. And you can see if you have these T3 and T4 tumors, higher grade tumors that impact on performance status, these drop people into a high risk category for developing tumor recurrence. And when you look at the survival of these high-risk patients, you can see once again, as your risk increases, your risk of death increases also. And the high-risk non-metastatic patients actually have long-term survival that's out to 10 years. That's very similar to the low-risk metastatic. So we'll move to case number one. This is what we consider a complicated locally advanced kidney cancer, a tumor that has an IVC involvement, has regional lymph nodes, and adrenal involvement. This is a 71-year-old woman. She presents with left flank pain and gross hematuria. A review of systems shows she's had some weight loss. She's had a decline in her performance status with fatigue and anorexia. Physical exam shows some fullness in the left upper quadrant with a little tenderness. Bone scan and other imaging was negative. She does have some anemia. Her LDH was elevated. Her liver functions were normal. Her alk phos was normal. She had a CT showing some involvement in the inferior vena cava. There's a large local tumor. There's some periaortic adenopathy. You can see extension of the tumor into the renal vein. MRI was performed, and the cephalad extent of the tumor thrombus is a sort of retrohepatic. It's probably a little bit below the confluence of the renal veins, the hepatic veins. So could we go to the ARS question? What would be the best initial treatment for this patient? And choice A is left radical nephrectomy, IVC thrombectomy with a lymph node dissection. Choice B would be the same, but preceded with a tumor embolization. Choice C would be systemic targeted therapy, followed by a delayed nephrectomy in responders. And choice D is biopsy of the primary tumor, then using histology to guide the choice of initial systemic targeted therapy and delayed nephrectomy only in responders. So looks like about half of respondents would go to immediate surgery. The next most common choice, choice D, was biopsying the tumor and using histology to guide choice of initial systemic targeted therapy. So in this case, the patient did undergo a biopsy. The biopsy was diagnostic for clear cell renal cell carcinoma. It was read as a high-grade tumor. What would be your choice of pre-surgical neoadjuvant therapy? And the choices are cytokine therapy, either interleukin or interferon, a VEGF TKI, an mTOR inhibitor, or choice D. I didn't want a biopsy. I was ready to do surgery right away. So it looks like the choices are split between using a VEGF TKI versus going to immediate surgery. Could we go back to the slides? So in this case, the patient went for immediate surgery. You can see this patient had a large tumor, 21 centimeters. Even without a TKI inhibitor, there was extensive tumor necrosis. This was a clear cell tumor. It was a high-grade Furman tumor. It showed extension through the capsule, extending into the fat. There was the IVC extension. The tumor also, our pathologists tell us, was positive for CA9. So this is a T3B N1 tumor, clear cell high grade. And the patient is now completely resected as NED. And what do we do with this patient now? Choice A, using sunitinib for 1 year post-op. Choice B, enroll them in a clinical trial for adjuvant therapy. Choice C, surveillance every 3 months for 2 years. Or choice D, take harvested tumor from the surgery, make a vaccine, and administer post-operatively. So most of the respondents chose B, which is enrollment in a clinical trial for adjuvant therapy. Next, choice A was using a sunitinib for 1 year post-operatively.